Bismillah ar-Rahman ar-Rahim. Today we are going to discuss how to read a complete blood picture or a CBC, how to interpret a CBC. My name is Ahmed Darwish, an Associate Professor of Pediatric Hematology, Oncology, and Bone Marrow Transplantation. First of all, we have to know that the parameters of a CBC include a red blood cell count, a hemoglobin level, a hematocrit value, blood indices including MCV, MCH, MCHC, total leukocytic count together with a differential leukocytic count including neutrophils, eosinophils, basophils, and monocytes, and the platelet count. We are going also to discuss a reticulocytic count, red cell distribution widths, mean platelet volume, and so on. Before going through interpretation of a CBC, we have to know that the parameters of a CBC differs according to the age. One of the most important features is that the hemoglobin level is so high in the first day of life, ranging from 14.5 to 22.5 gram per deciliter. So a baby who is just born is considered to be anemic if the hemoglobin level is below 14.5. But after the first week of life or during the first week of life, the cutoff limit of anemia decreases from 14.5 up to 13.5. And in the second week, it becomes 12.5. Reaching the first month, it's 10. And reaching the second month, it is 9. Then rising back to 9.5, 10.5, and in the preschool age, to the 11.5. And in the childhood period, it's 12 in females and 13 in males. And in adolescence and adulthood, the female cutoff limit for anemia is 12, and the cutoff level for males is 13.5. The same is occurring for MCV, mean corpuscular volume, where the size of RBCs are a little bit large in the first day of life, coming to a level of 70 to 86 at the age of 6 months, then rising back, reaching 80 to 100 in adolescents and adults. What is happening for hemoglobin and MCV is just it was high, then low, then becoming higher again. But for white blood cell count, the white blood cell count is very high in the first day of life, ranging from 9,000 up to 30,000 per microliter. However, it decreases, being the maximum limit for white blood cells in the first week of life is 21,000. Then first month it's 19.5. 6 months it is 17.5. 1 year it's 17.5. 2 years it's 17. 4 years it's 15.5. Reaching the adult level in the adolescence from 4.5 to 11. But what about platelet count? The platelet count is steady, the same all through life. What are the blood indices? They include the mean corpuscular volume, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentration. A mean corpuscular volume means it's a mean for the volume of RBCs. So we have to take the volume of whole RBCs, which is the hematocrit value, over the count of RBCs in millions. Okay, and we have to multiply it by 10 in order to know the exact mean for red blood cell, for the size of the red blood cell. So it's about 90 femtoliter. Okay, and the mean corpuscular hemoglobin, it is just dividing the hemoglobin by the RBCs count in million and multiplied by 10 in order to get the mean corpuscular hemoglobin, which is about 30 picogram per. It's about only 30 picogram from 27 to 32. And the mean corpuscular hemoglobin concentration means the concentration. It is hemoglobin over hematocrit, the mass over volume, and multiplied by 100 to get a percentage. It's about 33%, which means that the hemoglobin is occupying 1/3 of the RBC size. The normal mean corpuscular volume is ranging between 87 to 92. However, we consider the MCV low if it is less than 75 femtoliter, whatever the age in children, and being high if it's above 100. And the mean corpuscular hemoglobin concentration, we consider it if the MCH is less than 27, so it's hypochromic. What about the mean corpuscular hemoglobin concentration? It is just the concentration of hemoglobin in the RBCs. So it's hemoglobin over hematocrit. And it's said to be 33%, as I mentioned. The MCHC is increased more than 33 in patients with spherocytosis especially. And this diagram shows that in the bottom that the blue dots are denoting the mean corpuscular volume. However, this triangular part on the left inside the cell is denoting or is simplifying what is the MCH. And if you just divide the MCH by the MCV, it gives you the mean corpuscular hemoglobin concentration. On the top, we can see an electron microscopic picture of RBCs, which show that the red blood cell is biconcave in shape. However, we can never tell the shape of the RBCs only by an electron microscope, but we call the blood film. So, I have to mention the classification of anemias. We have the microcytic anemia, including the iron deficiency, thalassemia, chronic hemorrhage, lead poisoning, sideroblastic anemia, chronic infection, and we have the macrocytic anemia, which includes megaloblastic anemia as vitamin B12 deficiency and folic acid deficiency. We have also the normocytic normochromic anemia, which include hemolysis, decreased production as in bone marrow failure, aplastic anemia, leukemia, and we have the acute hemorrhage as well, and all the hemolytic anemia except thalassemia, as I mentioned. What about the red cell distribution width? The red cell distribution width, just a variability in the RBC size. It measures the variability in RBC size. It's normally between 11.5 to 14.5. If it's more than 14.5%, this means that we have a problem, deficiency of the materials needed for RBC's formation, like an iron deficiency or vitamin B12 deficiency. What's a reticulocytic count? It is an index for bone marrow activity. It's usually between 0.5 to 2% or 3%. If it's higher than expected, so we are expecting a bone marrow hyperplasia. But if it's less than 0.5, we are just suggesting a hypocellularity of the bone marrow. But let's say that a reticulocytic count is just giving you a picture for 1 ml of blood. However, if we won't make it corrected according to the whole blood, so we'll do what we call corrected reticulocytic count, which is equals to reticulocytic count multiplied by the hematocrit of the patient over the normal hematocrit. So once it's determined that the child is anemic, the first step is to evaluate other elements like white blood cell and platelet, because it could be just an anemia or it could be a pancytopenia or a bicytopenia. And then the second step, we have to know whenever we have a CBC, we have anemia, especially, we have to know exactly, is it normocytic, macrocytic, or microcytic, depending on the MCV and the MCH and MCHC. And we have to see the red cell distribution width, because it can just tell us, for example, in cases of microcytic hyperchronic anemia, is it a case of iron deficiency or a thalassemia and so on? Do we have an isocytosis or not? And we have to do some additional investigations, like knowing the reticulocytic count is very important. And don't forget that we have to do a blood film. Okay, if you look to this blood film, it can show the normal size of RBCs. Oh, the count is low of the cells, but the size is normal, and the amount of hemoglobin in each cell is normal as well. So this is a normocytic normochromic. And these cells have got a biconcave shape. Why? Because we have a central pallor, which is very minimal central pallor. However, this case, it is a case of microcytic hypochromic anemia, showing a wide central pallor and a small side cell. But in macrocytic anemia, the cell size is large, like in patients of megaloblastic anemia, folic acid deficiency, vitamin B12 deficiency. Okay, what a blood film can tell us. The blood film can tell us about the size of RBC, the shape of RBC, the number of RBC, the abnormal forms of cells. One of these abnormal shapes, it could be a target cell. The target cell is very common in thalassemia, but can occur in some other cases like in iron deficiency. It looks like a target sheet. Spherocytosis, one of the autosomal dominant diseases. Usually the cell, it is a spherocyte, so it have got no central pallor. And usually the MCV is less than expected and the MCHC is higher than expected. This shape called elliptocyte, one of the rare diseases, 1 over 1 million, and it's usually leads to hemolysis, and it's also an autosomal dominant disease where the shape of the cells are elliptical in shape rather than rounded. Other abnormal forms, which is also a rare condition, is called stomatocytosis, in which the central pallor is not rounded, but it looks like a mouth. It's a stomatocytosis. Okay. One of the most common causes of microcytic hyperchromic anemia is lead poisoning. And in lead poisoning, usually we have in the blood film what we call basophilic stippling. Whenever you have these basophilic stipplings in the blood film, you have to go further to do what we call serum lead to see whether we have lead poisoning or not. Okay. We mentioned that the microcytic hyperchromic anemia, it is the most common type of anemia. The most common 2 causes of microcytic hyperchromic anemia are iron deficiency and thalassemia in our locality in Egypt. Both are microcytic hyperchromic anemia, but in cases of iron deficiency, the reticulocytic count is usually low or normal. However, in thalassemia, it's high. In iron deficiency anemia, the history is usually giving a history of a poor diet, poor weaning, cow milk intake, sometimes exclusive breastfeeding, and so on. However, in thalassemia, the history is usually jaundice. We have hepatosplenomegaly, frequent blood transfusion, mongoloid feces, sometimes positive consanguinity. Iron deficiency is diagnosed by an iron profile, especially serum ferritin or transferrin saturation. However, for thalassemia, the iron is high, is very high, due to blood transfusion. And the diagnostic test is hemoglobin electrophoresis or a gene study. And this table can show you the difference between iron deficiency anemia and thalassemia minor, because sometimes thalassemia is not so evident and the hemoglobin is not so low. So we have to differentiate between both types. If you look to the anisocytosis or the RDW, it's very early and prominent in iron deficiency, but it's mild or absent totally in thalassemia minor. And that's why the RDW is high iron deficiency and it's normal in thalassemia minor. Both have got microcytosis. But the microcytosis in thalassemia minor is more severe than iron deficiency. The target cells are usually present mainly in thalassemia rather than in iron deficiency anemia. And we have the Mensur index, which is MCV over their RBCs. If the MCV over RBCs is more than 14, so it's usually iron deficiency. But if it's more than 14, but if it's less than 12, it's usually thalassemia minor. For the serum iron and serum ferritin, both are low in iron deficiency, but both are high or normal in thalassemia minor. However, the TIBC, the opposite, it's high in iron deficiency, low or normal in thalassemia minor. And the free erythrocyte protoporphyrin is high in iron deficiency anemia, it's normal in thalassemia minor. These are some of the causes of microcytic hyperchromic anemia, like thalassemia, chronic infection, chronic renal failure, lead poisoning, sideroblastic anemia. Thalassemia is diagnosed by hemoglobin electrophoresis, chronic infection by history, renal failure by history and serum creatinine, lead poisoning by occupational history, examination sometimes, serum lead, basophilic stippling, and the sideroblastic anemia is usually diagnosed during a bone marrow aspiration, revealing sideroblasts in the bone marrow. These are the shapes of the sideroblasts in the bone marrow. We have, it could be just congenital, it is an autosomal recessive disease, or it could be acquired, like in pyridoxine deficiency, where the protoporphyrin is low, so the iron is just deposited in the center in the mitochondria. Two of the most common causes of pancytopenia in children are aplastic anemia and hypersplenism. But in hypersplenism, the spleen is large, and usually we have high reticulocytic count. However, the pancytopenia of aplastic anemia is usually associated with low reticulocytic count, or it's normal, no organomegaly. And then you have to do bone marrow aspiration and biopsy to diagnose it. We reach the algorithm or the approach for a case of a CBC. So whenever you have a CBC, you look first for the hemoglobin level. If the hemoglobin level is within normal, so you have to look for white blood cells and platelets. Of course, we can have a platelet count which is low only. It could be an ITP, or it could have white blood cell count which is low only in cases of viral infection, or it could be high in viral or bacterial infection or in leukemia. But what if the white blood cell and platelets are within normal? So we are dealing with a normal CBC. But what if the hemoglobin level is already low, an average less than 10 gram per deciliter, or differs according to the age? Hemoglobin is low, we look further to the white blood cell and platelets. So if the white blood cells and platelets are also lower than expected, so we're expecting pancytopenia. And this pancytopenia, it could be variable of causes, but the most common two are aplastic anemia and hypersplenism. So we have to go further for reticulocytic count. So if the reticulocytic count is low, so we are expecting failure or aplastic anemia. It could be a case of Fanconi anemia. But Fanconi anemia differs from aplastic anemia in its congenital anomalies like microcephaly, microphthalmia, like absent thumb, like renal anomalies, cardiac anomalies, and usually the mean corpuscular volume is higher than expected, reaching 95 or 100. Okay, but if the reticulocyte count is high, so we are expecting it to be hypersplenism. Okay, let's go for the CBC if the white blood cell count and platelets are within normal. So we are dealing with a patient with anemia only. Whenever you have a patient with anemia, you have to look further for the blood indices like the MCV, because if the MCV is high, more than 100, expect macrocytic anemia like megaloblastic anemia, vitamin B12 and folic acid deficiency. But what if the MCV is lower than expected? So think of doing a reticulocytic count, because if the reticulocytic is normal, it could be, or low of course, it could be iron deficiency anemia or chronic infection. But if you are expecting thalassemia or chronic hemorrhage. But what if the MCV is within normal, 75 to 100? So we have to look for reticulocytic count low, so we are expecting pure cell aplasia or hypoplastic anemia. What if the reticulocytic count is high? So it could be either normocytic normochromic hemolytic anemia as G6PD deficient sickle cell or spherocytosis, or it could be an acute hemorrhage. Okay, let's go for some cases. If this patient is hemoglobin 5 and the total leukocytic count is 2000, platelets are 50,000, so we are dealing with a pancytopenia, but the reticulocytic count is 0%, so it's a case of aplastic anemia, of course. Other patients have got only anemia with an MCV is 120, so you have to think of macrocytic anemia, like megaloblastic anemia. Another with anemia only, but have reticulocytosis, and the MCV is 70. So it's a microcytic anemia with high reticulocytic count, so it could be thalassemia, beta thalassemia. Other patient, the same, but with the reticulocytic count is 1%, so it's iron deficiency anemia. Another who have got normocytic anemia because of MCV is 85, and reticulocytic count 7%, so you are expecting hemolysis. So it could be normocytic normochromic hemolytic anemia. So the only option here would be sickle cell anemia. What about a patient who have got normocytic anemia but with an MCV with a reticulocytic count of 4%? So you are expecting spherocytosis, or it could be not spherocytosis because we don't have a spherocytosis. It could be an acute hemorrhage, or spherocytosis, as I mentioned. What about cases? Suppose that a child who is 5 years old, male, presenting with pallor, jaundice, mongoloid fishes, receiving blood 10 times, no purpura, but have got a huge spleen, no generalized lymph nodes, or fever. This is the CBC showing, of course, anemia, which is severe microcytic hyperchromic. So what to do next? I think that we have to do reduced count next, because it will be increased. And if increased, we have to think of thalassemia in order to diagnose thalassemia. Don't forget that we have some clinical or diagnostic tests for chronic hemolytic anemia, like electrophoresis for thalassemia sickle cell, osmotic fragility in spherocytosis, sickling test for sickle cell anemia. These are the cells which have got target-shaped cells in thalassemia, and these are the cells who have rounded shape. These are spherocytes, spherocytosis, have got no central pallor inside. And these cells are pointed, they are the sickle cell anemia. And the sickle-shaped cells have got the power to do some occlusion of blood vessels and can lead to pain late at night. Another child is a female, 4 years old, presented mainly with illness and high-grade fever, with purpura all over the face and the forearm, with hepatosplenomegaly and lymphadenopathy. When a CBC is done, reveals anemia. It's normocytic normochromic anemia, but with hyperleukocytosis and thrombocytopenia. So how do you think? I think you have to think of leukemia. So you have to do for the bone aspiration. When bone marrow was done, aspiration was done, it revealed just infiltration with blast cells. It's about 80%. Okay, so now the patient is a case of acute lymphoblastic leukemia. In a 10 years old male, who is presented mainly with high-grade fever, mouth ulcers, purpuric rash all over the body, no hepatosplenomegaly, no generalized lymphadenopathy. So this patient, CBC revealed anemia, which is normocytic normochromic anemia, with a total leukocytic count less than expected, leukopenia, and the platelet count, which is only 35%. So you have to think of a pancytopenia. We don't have spleen, we don't have lymph nodes. We have a bad general condition. We have to think of aplastic anemia, but we have to do further bone marrow aspiration and biopsy, where it revealed necrosis and fat cells, so it's usually aplastic anemia. Last case here, we have a female infant, aged 9 months, presented with cow milk feeding, no weaning till now. I've got pallor, mild liver and spleen, no lymphadenopathy. And I've got severe anemia, severe microcytosis. So what to be done next? Oh yes, specific count which is normal or decreased. So you have to think of iron deficiency. So I have to go further for the serum iron, serum ferritin, TIBC, usually diagnosed as low serum ferritin, but if serum ferritin is not low, we have to divide iron over TIBC to get what's called transferrin saturation. It's less than 16%, so you have to think of iron deficiency. Thank you all.